According to the most recent publication of WHO Global TB report, you can see it right now on your screen. The burden of tuberculosis in the world is high. In 2011, 8.7 million new TB cases were estimated to be developed, and 1.4 million people died of TB. Drug-resistant tuberculosis is one of the major issues in TB control, and the level of drug resistance is increasing every year. For 2011, it is estimated that 3.7% of new cases and 20% of previously treated cases were MDR TB. Through the global project on anti-tuberculosis drug resistance surveillance, which was launched in 1994, data on drug resistance is collected and analyzed from 135 countries. According to WHO estimates, in 2011, 310,000 MDR TB cases emerged in the world. 60% of them are in India, China, and the Russian Federation. And 630,000 prevalent cases, patients who need to be treated. Levels of drug resistance, both primary, when patient who has never been treated for TB is diagnosed with MDR TB, and secondary, for patients who have been treated for TB before, are rising. In 2011, the highest level were recorded in the Republic of Belarus, where 32.2% of new TB cases are diagnosed as MDR TB. However, based on subnational data from the Russian Federation, we learned that in Arkhangelsk Oblast, the level of primary MDR TB was about 35.1% in 2010. As we enter 2013, we may assume with good confidence that the level of primary MDR TB may be as high as 40% in some countries. The level of MDR TB among previously treated patients is even higher. According to the Global Drug Resistance Report, in 2011, secondary resistance in the Republic of Belarus was 75.6%. In the Republic of Moldova, 63.5%, and in Estonia, 57.7%. From this data, it is evident that MDR TB hotspots appear to be in the former Soviet Union countries. When we talk about MDR TB or drug-resistant tuberculosis in terms of detection and management, we are also keeping in mind so-called XDR TB, when in addition to resistance to isoniazid and rifampicin, the patient is resistant to an injectable agent and quinolone. And XDR TB plus cases, when patient is resistant more than 4 drugs or sometimes all medicines available in the country. According to WHO, the level of XDR TB is rising, and in 2011, 9% of MDR TB patients were diagnosed with XDR TB. In order to find drug-resistant tuberculosis, we, as a public health professionals, need to have access to drug susceptibility tests, so-called DST. Only when DST to first-line medications or even better second-line medications is done, we can find TB cases with drug resistance. The WHO established a target that by 2015, all suspected MDR TB cases among new patients should receive at least first-line DST. In terms of percentage, it was estimated that globally this percentage would be about 20%. However, the same targets state that for previously treated TB patients, DST should be performed for all 100% of patients. The same applies to MDR TB cases, meaning that all of them should be tested for XDR TB. There are the targets to be achieved by the end of 2015, but what are the results for 2011? Globally, as you can see on your screen right now, 3.8% of new TB cases were tested for MDR TB. Among 27 high-burden countries, this percentage is even lower, only 2.6%, as you can see. And previously treated patients, for previously treated patients, results are even also low. Globally, only 6% tested. You can see it right here. How about a number of patients who were detected? In 2011, only 59,000 MDR TB patients were detected among both new and previously treated. Since the global estimate was about 310,000, the number of actual cases detected represents only 19%. As you can see, detection of MDR TB is a very big issue globally, and particularly for the high-burden TB countries. That's why our first talk today and in this webinar course will focus on TB detection and will be presented by Dr. Jared Skolton from the Keen CV Tuberculosis Foundation. Once MDR TBs are detected, we need to start appropriate treatment to prevent further dissemination of drug-resistant strains in the community. But what are the appropriate treatment regimens? Can we count all patients who have started on TB medications and enroll them for treatment? Answers to these questions will be presented by Dr. Salman Keshavji this Thursday on March 14th. Dr. Keshavji is an associate professor at Harvard Medical School and also a senior TB advisor at PAH. He will provide you with international guidelines and also practical experience from the field. On March 19th, on Tuesday next week, we will have a webinar on infection control basics for an MDR TB program implementation. This talk will be given by Professor Edward Nardell. He's a well-known expert in infection control, and I encourage you to ask him questions about infection control measures in different treatment settings, such as clinics or community, or when we provide medical care for patients at their home. When we are trying to control tuberculosis, our goal is not just to treat existing patients, but also to prevent further transmission. And you will be able to discuss this with Professor Nardell during the presentation. Treatment of any TB case, sensitive MDR TB, XDR TB, is not possible without anti-tuberculosis medications. For drug-resistance cases, we use so-called second-line medications because only they can kill mycobacteria resistant to the isoniazid and rifampicin. For many programs, especially at the peripheral and district levels, uninterrupted supply of quality-assured medications is a big challenge. What we often see is that MDR patients receive a lower number of drugs than they were prescribed because some drugs are not available due to stock outs. Also, when we look at the delivery chain, we may find that drugs are not delivered in the right condition or not stored according to manufactured prescribed norms. That's why on March 21st at 9 a.m. Boston time, we will have a presentation on drug management. Another topic which will be presented in our course is the treatment of MDR patients in the community. According to the WHO Global TB report, many MDR high-burden countries hospitalize their patients at the beginning of treatment. Many countries in Eastern Europe hospitalize 75 to 100% of patients. In Africa, while some countries hospitalize only 10% of their patients, there are other countries which hospitalize as many as 70 to 95% with an overall duration of hospitalization up to 240 days. WHO recommend that MDR TB treatment is provided in outpatient settings, so-called ambulatory or in the community. However, many doctors and public health practitioners who are providing care to drug-resistant TB patients are afraid to do so in the outpatient setting. Our fifth talk will be given by Dr. KJ Seung, who is a Deputy Director for the PH Lesotho project, where all patients are treated in the community. I'm encouraging you to join this presentation on March 26. Finally, our sixth talk will be organized on March 28th at 8 a.m. Boston time. We are going to talk about adherence to TB treatment and how to improve treatment results. Dr. Irina Germanova, who spent more than 9 years working with PH Russia project in Tomsk, will present international experience and practical suggestions and steps to be implemented in order to improve success rates. Why is this topic important and why we are talking about it in our course? Because all of our activities in detecting DR TB patients, enrolling them into the treatment, will be wasted if only half of the patients enrolled for the treatment finish it successfully. To be more accurate, the average global success rate is around 48% only. This is too low compared to the target set by WHO of 75%. Currently, 28% of patients are defaulting on their treatment. Please pay attention to this talk, that this talk will start at 8 a.m. Boston time instead of 9 a.m. as all our first 5 talks. I have briefly presented you with an overview of the global situation on detection and treatment of MDR TB and describe the talks that we will going to present over the next 3 weeks. Each talk will discuss practical activities that each project needs to implement in order to be successful.